Welcome back to our series on head and neck tumor staging. In today's video, we begin with one of the most important anatomical regions, the oral cavity, including the mucosal lip. In this session, we will go through the key subsets of the oral cavity, understand their boundaries, highlight the essential points that influence how tumors in this region are staged. This will be this will lay the foundation for understanding the site-specific staging rules in the upcoming videos. Let's get started. The oral cavity, including the mucosal lip, they include the buccal mucosa, the mucosa of the upper and the lower lip, the cheek mucosa, the retromolar areas which are behind the last molar, mandibular molars, the upper and the lower alveolar processes and the overlying gingiva, that is the upper and the lower gum, and the bucco-alveolar sulci, the upper and the lower. The space between them is the vestibule. The hard palate, and a line drawn from the junction of the hard and the soft palate to the hyoid bone marks the posterior boundary of the oral cavity. So the tongue anterior to this, which is or the tongue anterior to the circumvallate papillae, the anterior two-third of the tongue, the oral tongue or the mobile tongue is within the oral cavity. The floor of the mouth is below the oral tongue, and the inferior extent is marked by the mylohyoid sling muscle, which is extending between the mylohyoid ridges from the inner aspect of the mandible on either side. That is the floor of the mouth. Now coming to the TNM oral cavity cancer, T1 stage is when the tumor size is 2 cm or less in greatest dimension and 5 mm or less of depth of invasion. And it is T2 when the tumor size is 2 cm or less in greatest dimension, or if the depth of invasion is more than 5 mm, or tumor size is 2 to 4 cm in greatest dimension and the depth of invasion is not more than 10 mm. T3 is when the tumor size is more than 2 centimeters but not greater than 4 centimeter in the greatest dimension, and the depth of invasion is more than 10 mm, or tumor size is more than 4 centimeters in the greatest dimension but the depth of invasion is less than 10 mm. T4A is when the tumor size is more than 4 centimeter and the depth of invasion is also more than 10 mm, or tumor invades through the cortical bone with involvement of spongiform bone of the mandible or maxilla or involves the maxillary sinus or invades the skin of the face. T4B is when the tumor invades the masticator space, pterygoid plates or skull base, or encases the internal carotid artery. Of note, the superficial erosions alone of the bone or the tooth socket by gingival primary is not sufficient to classify a tumor as T4A. It has to go to the marrow of the bone. Superficial invasion of the adjacent skin from the lip, like the dry vermilion or the vermilion border of the lip from the mucosal lip, is not sufficient to be classified as T4A tumor. Coming to the concept of this depth of invasion, when we assess tongue cancer, two measurements often appear similar but actually mean different things: tumor thickness and depth of invasion. Tumor thickness is simply the vertical height of the tumor itself from its very top surface down to its deepest point, but the depth of invasion is what we actually use for T category staging. Depth of invasion measures how far the tumor has grown down from the normal surface of the tongue, not from the top of the tumor. So even if a tumor is ulcerated or sticks out above the surface, depth of invasion ignores the protruding part. It only measures how deeply it has invaded into the tongue tissue. So the key difference is tumor thickness is, it's from the top of the tumor to the deepest point, whereas depth of invasion is original mucosal surface to the deepest point of invasion. This means depth of invasion is better indicator of how aggressive the tumor is and is used directly to determine the clinical T classification in oral tongue cancers. This schematic helps show the depth of invasion is usually smaller than or different from tumor thickness, depending on whether the tumor is exophytic growing outwards or ulcerated or shrunken. Let's see here. See this, the blocked blue thing is the closest mucosal surface and the black dotted interrupted line is the interrupted submucosal plane. The green is the tumor. So the tumor thickness is the entire measurement of the tumor, the green, from the top of the tumor to the deepest point of the tumor. That is the tumor thickness. Whereas depth of invasion is marked by the red solid arrow. This is measured from the interrupted mucosal plane, the original mucosal layer, to the deepest point of the invasion. If the tumor is from the tumor thickness and the depth of invasion will be equal when the tumor is a flat tumor, whereas an exophytic tumor, the tumor thickness will be more because we will not measure, the depth of invasion will be measured from the mucosal surface only. Whereas in ulcerated or the shrunken lesion, the tumor thickness will be small but the depth of invasion is greater because we have to measure from the normal mucosal line. Coming to the regional lymph nodes, end staging. N1 single ipsilateral node 3 cm or less in greatest dimension without clinical extranodal extension. N2 is subdivided into 2A, which is single ipsilateral node more than 3 cm but not more than 6 cm in greatest dimension without clinical extranodal extension. 2B, multiple ipsilateral nodes not more than 6 centimeters. 2C, bilateral or contralateral nodes not more than 6 centimeters again. And 3A is node which is more than 6 centimeter in greatest dimension. 3B is with clinical extranodal extension. So the numbers to remember, same side single node 3 centimeter or less is N1, N2A is single node more than 3 centimeters. 2B is multiple ipsilateral, 2C is bilateral or contralateral, 3A is more than 6, 3B is with extranodal extension. Clinical extranodal extension is the presence of skin involvement of soft tissue invasion with deep fixation to the underlying muscle or adjacent anatomical structures or clinical signs of nerve involvement. Imaging is becoming a standard method of detecting unequivocal extranodal extension, IENE. This is more detail. This is coming up in the new AJCC edition. Midline nodes are considered the ipsilateral node.